Hi, I'm Luis Riquelme, and I'm here to talk to you today about professional diversity, how your unique perspective can improve clinical decision-making. My disclosures include my position as Associate Professor at New York Medical College, Director of Barriga Speech-Language Pathology at New York Methodist Hospital, and I am receiving compensation for this presentation. Non-financial disclosures include my position as Chair of the American Board of Swallowing and Swallowing Disorders and several awards I've received from ASHA, including the Certificate for Recognition for Special Contributions in Multicultural Issues. So why is this important? Why are we talking about professional diversity today? The truth is, it impacts us in many different ways. I remember when I entered the profession, people making a big deal about the fact that I was a male. People also making a big deal about the fact that I was a bilingual Spanish speaker. And so I didn't always understand that, especially not during my initial years in the career. And as I learned more about the patients I was working with, about being able to reach appropriate diagnoses, and along with my exchanges with other colleagues as well, I realized, yes, diversity does matter. It is important in everything we do. There are people that not only need specific types of clinicians because of their language background or their cultural backgrounds, but there's also the reality that we as professions are serving a greater society, and we want to try to mirror that society as best we can, or understand that society as best we can. So diversity does impact our exchanges, our decision-making on a regular basis. So what is this diversity all about? We really need to understand what diversity is. In our professions, we speak a lot about culture, multiculturalism, and cultural and linguistic diversity. And but when we speak about diversity, that's the only connection we make. The truth is that diversity in all we do, in our interpersonal communication with our patients or clients, our perspectives about diversity really influence how we make decisions. So, for example, many years ago, I started attending ASHA conventions, and so in the late 90s, and those were the days when we wore shirts and tie to convention on a regular basis. Luckily, we're more relaxed these days. I would greet female colleagues with a hug. And I often got pushback. As a Latino male, that was not a big deal for me because I felt that that was the way we always greeted people. You always said hello and you hugged them. Now, fast forward 30 years later, and now that is totally accepted practice. It is not unheard of to hug a colleague when you see them or when you meet someone. So times have changed, and so change is possible as long as we understand that we all bring certain diversity to the different contexts and to the different environments that we're in. So it depends also on our paradigms. So paradigms within our professions, paradigms about culture and how they impact everything we do. Perspective taking is quite an important aspect of trying to understand diversity. Basically, we always think about us as the clinician or us as the person in the center and how then we impact the interpersonal communication, how we impact the clinical situation, but we don't often think about how our patients or clients are actually thinking about us. How do they view us as service providers? Are we in that authoritarian role? Are we simply just a consultant, and the bottom line is the patient or the client will have the ultimate decision? So is this whole aspect of cultural sensitivity and cultural competence truly a bilateral process, or is it just one-sided? And when we think about perspective taking, Sanchez in 2008 spoke about how persons receiving services are not often expecting culturally competent services. So in many situations, our patient or client is just expecting that it will be one more situation where they are not as involved. Totally interesting to note when we have been working for many years on that collaboration with our patients and clients. So we don't set goals, for example, on our own. We consult with our client or their caregiver on what goals for treatment we'll need to establish. So there's a very interesting way to go full circle in this exchange. As we then move forward in continuing to try to understand diversity, there's the thinking about why. Why is this important? Why do we need to do this? How is it going to impact our clinical practice? And the truth is, if we want to create an environment where we can connect with our patient or client, where we can obtain the information we need to make better decisions, if someone isn't going to share information that is relevant to the particular evaluation we're doing, whether it's the caregiver of a child with a speech or language disorder, whether it's the parent of a child with a hearing impairment, whether it's an adult with complaints of dysphagia, we want to get a good picture. And we do know that our diagnostics are really guided by a good interview. So that's the chance we have to create that more balanced environment and get the information that we really need from our patients or our clients to then start formulating our hypotheses, to then really start reaching an appropriate diagnosis and eventually a treatment plan if needed. That balance between the clinician and the patient is something that I once again, as I said previously, need to focus on and really maintain and create that environment in our practices. So I'll share with you a few examples of some situations that I've been involved in, and either the fact that I am Latino, or the fact that I'm a male, or the fact that I'm gay have influenced the different interactions with patients. So let's talk about patient A in this illustration. So this man was a 72-year-old male, of religious Jewish background. He was a rabbi, and he was diagnosed with Parkinson's disease. And his focus or his interest was to be able to keep up, basically, during morning prayer in the synagogue. He had no concerns over the fact that his wife did not understand him or that his family members did not understand his speech. His total focus was on morning prayers. Well, that was a total switch in terms of how I was going to provide treatment because, of course, my focus always had been on being intelligible in all contexts. So we then decided to use prayers as part of our treatment materials. I did not understand the language, but again, how does this really tie in here? Well, one, he only wanted a male clinician. Okay, so he got a male clinician. He probably would have benefited from somebody from his own religious group, etc. However, since that was not possible, we created an environment where I also made sure that I learned about what his environment was like, what his needs were, the importance of morning prayer to him, and then use that for in treatment. And that was the measure of how we were going to determine when he was ready for discharge. He also allowed, which I understood from the beginning was atypical, for his wife towards the end of treatment to come in and assess and determine his intelligibility during prayers. So that's one way we can really just tackle diversity. We will never be at the point where will match the culture or the diverse backgrounds of our patients and clients with a clinician. We're just not there yet, and I think it would be really unrealistic at this point. So let's talk about patient B. So patient B was a 28-year-old female, and this is someone I saw back in the mid-90s, and you'll understand why that's important in a few minutes. And she was Latina. She suffered a CVA during delivery, and that resulted in a significant oropharyngeal dysphagia and a flaccid dysarthria. One of the findings of her diagnostic workup was that she really couldn't manage thin liquids. And so we had to recommend nectar-thick liquids for her, which she really did not like. Now, our science in dysphagia has changed quite a bit since the mid-90s. So I want to remind you again, this was the mid-90s. We only had starch-based thickeners, and she did not like them. But her priority was her coffee. So let me remind you also about coffee. The coffee culture started in the early 90s in the US. So now we're talking mid-90s, yet for some groups within the US, coffee has always been important. And for Latinos, drinking coffee as a child is not a problem. I understood that because we shared that commonality. So we talked about coffee. She wanted her coffee. She didn't like it with thickeners. I was wondering if she was thickening properly. We had coffee in session. We mixed it. It still didn't really work out too well for her. We tried crackers. That didn't work out too well for her. And so we had to talk about the reality of what was the risk of her sipping some coffee, and we tried some compensatory strategies. We created that open environment because we both were on the same platform. We know she needed her coffee, she wants her coffee, let's go for it. Again, today, coffee culture is wild. So if one of your patients says to you, I have to have my coffee, you understand that, and you can do different things to accommodate that patient. Mid-90s, we weren't there. If people could not manage thin liquids, we'd say, that's it, you can't have the coffee. So just one thought, again, in mixing diversity into our clinical practice and how that made a difference for this patient, who eventually didn't need the thickeners once she was discharged from treatment. So let's talk about patient C. And I have colleagues that probably have many other examples of this situation, but this is a 78-year-old male who saw me as an outpatient, presented with an atypical oropharyngeal dysphagia, secondary to late effects of radiation. There was some mixed findings regarding his workup up until the point he made it to see a speech-language pathologist. And so we really needed to spend a good time during the interview understanding what was going on, etc. He was also in a bit of denial. And I say that because then I really needed to find out more about his family and what other people said, etc. I'm usually very relaxed and very comfortable in the clinical setting. And so during the interview, it was clear to me that, or at least I thought that this might be a gay man. And so I disclosed something personal about, I think I might have said something like, you know, my husband so-and-so, in the context we were talking about different foods, which is always fun when you're doing a dysphagia evaluation. And so I could see the change in his body when I said that. He relaxed more. He was able then to share with me what his husband was sharing with him about the difficulty he was having with swallowing. He didn't feel he had a problem, but his husband said he did, et cetera, et cetera. How else would I have gotten that information if I didn't create that relaxed environment for him to be able to share that? So this isn't a story where we misdiagnose someone. I know there are examples, colleagues that do more work in voice could share. There are examples of discrimination, etc. But I'm focusing more on the fact that we as professions that deal with communication want to learn how to create environments and be comfortable and let people know that we're part of the puzzle in terms of our clinical interaction and in terms of moving forward with reaching a good diagnosis and a good treatment plan. So by just creating that familiarity, we were able to then do a better instrumental exam and then set up a better treatment plan for him to follow. So is change possible? Well, we have to be optimistic. There's just no way around it. I mean, think about where we are. We are at the end of a two-term president who is black. Whoever thought that would be possible? We have a Latina justice in the Supreme Court of the United States. Whoever thought that would be possible? And then the other reality is, look at marriage equality. Look at how people looked at marriage equality at the beginning of this century, and look at where we are now. So change is possible. It takes time, but it is possible. And the impact that has on our professions is very direct. When would some of our pioneers in speech-language pathology and audiology have ever thought that we would be in a radiology suite assessing swallowing, or conducting intraoperative monitoring, or maybe even utilizing endoscopes to assess swallowing? So change is possible. It means that we need to look at all the different key factors that lead us to, again, the bottom line, which is reaching the appropriate diagnosis and coming up with a good treatment plan. So then self-exploration is something to discuss. We tend as a people to stereotype. And so that's just a natural cognitive response to looking at people and putting them in categories. Our patients do it with us. We do it with them when they walk in the door. We need to understand that. And so while we might start, and I usually start with trying to equal the scale in the clinical exchange, so that power balance, letting them know, yes, I'm here to help you, but I can't help you if you don't help me. So they're just as important in this equation of a diagnostic workup or of an evaluation. But it makes us also have to think about how we look at people. How do we define culture? How do we define differences? Do we assume that everybody of category A behaves the same, is the same, etc.? And so are these differences a problem? Are these differences a challenge? Or are these differences really an opportunity to grow and to be able to make a difference? We really need to think about that, and we need to think about the makeup of our professions and the makeup of our society as a whole right now. That brings us then to a very interesting concept that was brought forward in the late 90s. It actually all started in a medical school in California, and it was this concept of cultural humility. So first of all, looking at cultural sensitivity, cultural competence as a lifelong process. So we strive to become more sensitive, we strive to become more competent, but will we ever be? Can we ever be? Is it really a process that we keep growing into? And if we can understand that, then we'll be more vigilant about really acknowledging how that ties into what we do on a daily basis. So culture is a dynamic term, and I won't speak too much about culture here because I want to talk more about the impact this has on our interactions, why diversity is important to our professions. However, I will say that it's a dynamic term. There's not one definition, right? But I think we can agree that it's shared values and customs. And so we all present with many different cultures. So the same way that I might be a part of 16, 17, 25 different cultures, my patient or client will also be coming in the door with that many, if not more, cultures as well. And so it's beyond ethnicity. It's religion, it's lifestyle, it's, the group of people that shop at supermarket A. It's all the people that love the color purple. So those are the different cultures that we are all a part of. So there's no way we're going to know everything about our patient client, and there's no way they'll know everything about us. So how do we bridge that gap? And so can we start shifting our paradigms, our way of looking at that, so that we can really make inroads into that interpersonal exchange. And I'll give you an example. In the world of the practice of assessing swallowing disorders, for example, many people think that diversity really only has to do with different foods, different ethnic foods, etc. And there hasn't been enough attention paid to the interpersonal interaction, to the interview process, to that balance of power between the patient client and the examiner. So we need to look at that aspect, because how does that impact what we do? Well, it not only impacts our diagnostics, but then when we're thinking treatment, how about compliance? Why would the patient or client trust us? If we haven't created an environment of trust, then why would they follow our recommendations? Why would they believe what we're telling them to do? Why is it important to them? So let's look at that aspect of what we do. If we evaluate a child that has problems and parents aren't all there with the reality that their child is having communication problems, then why should they believe us? I mean, do we just assume that because we're the professional they came to, that we know it all and that they have to follow our recommendations? I would hope that by now, that's not the way we practice. So let's talk about making decisions and sharing of those decisions. So a few weeks ago, my team at the hospital said to me, Luis, we'd really like you to see this patient. We're having a hard time figuring out what the full picture is here. And so they asked me to see this 52-year-old female who was in our acute rehab unit and had just suffered her second stroke. She also had a past medical history of dementia and depression, which we were having a hard time understanding because of her young age and because of what we saw on the MRI of the brain. So I walk in the room and greet the patient, flat affect, not really engaged, and her two sisters were at bedside. I chatted with them a bit and found out that the patient is from Panama. So my assumption was, well, maybe she speaks Spanish. And so I asked her, and we had a brief exchange in Spanish. She was still as communicatively impaired as she was in English. However, she smiled and she seemed to perk up. I followed that by then speaking with the sisters and finding out a little bit more about her history. I was very concerned in terms of figuring out progress for this patient because of the diagnosis of dementia. What this all turned into, once I spoke with my team in the speech language pathology unit, was we were able to get psychiatry involved and come in and maybe look at managing her depression, which might have been creating that mimic of the dementia. And I will tell you that we changed our approaches a bit, and we started to see some progress in her intelligibility, which is what we were looking looking for first. So that brief little exchange, just finding out where she was from, just making that connection, gave us a little more information and allowed us to then go back to the larger rehab team and get another consultant in to help this patient. Had I not asked that, we wouldn't have found that out. So that sharing with our colleagues, that not thinking that we know it all, really does make a big difference. So to conclude our talk today, let's think about what you can do tomorrow in your clinical environment. How would you try to incorporate some of this thinking into your clinical environment? My first suggestion would be, if you do an evaluation, if you provide a treatment session, take a few minutes afterwards and think about what you could have done differently, or what did you do that was great, that impacted a better outcome in that situation. Again, whether it was a diagnostic or whether it was a treatment session. You might be at a loss. You might not know what you're looking for. There are many resources on the ASHA website. We also have the practice portal now. So look under cultural competence. There are some checklists that will help guide you as to what things you want to look at. But it might be something as simple as looking at your exchange. So reflecting on your exchange with that patient or with the caregivers. That might be one way to start this. Another way would be to be involved with the future generation of professionals. Help bring in others into our wonderful professions. And that could be by allowing a volunteer to observe you, by connecting with undergrad programs near your place of work, or simply by promoting the professions in different environments. So think about those as possible ways to start including that and improving your overall bag of tools to provide better service. So why is this diversity factor such a big deal in our professions? I mean, it does matter. I hope that with the few cases that I've shared with you, you understand that creating that open environment, that the fact that we all come in different shapes and sizes and colors does make a difference to the patients that we work with. Remembering that we're specialists in communication, and so we want to make sure that that exchange is effective and it's fruitful and it is significant. And we also have to deal with the reality that we are not only professionals, but we're also regular members of our society. So the influence our society has on us is there. It's significant, just as it is on our patient population. This ties in quite nicely with ASHA's strategic objective, number 6, which seeks to really increase the diversity of the ASHA membership. So in tying this together, what are we talking about when we say increase the diversity in our professions? Well, does it mean just increasing the number of people from different ethnicities in our professions? We know we're at a very low percentage compared to the general population. How about increasing the number of men? Why does being a male, is that significant to our colleagues and professionals? And there are situations where, as you know, it does make a difference. And so as we move forward, thinking about people from different backgrounds, and different backgrounds, again, is not just countries or ethnicities, different backgrounds of thought, different background of preferences, does make a difference. We all, as specialists in communication, want to really strive to make that environment the most positive as possible for our patients. So on a personal note, we really are in this big salad bowl. I mean, that's what the United States is. And no one is better than anyone else. We all bring different things to the mix, and it's really about our perspectives and our habits. On a professional level, our biases and our stereotypes need to be acknowledged. And we need to see that there is not one perfect way to communicate. There isn't one perfect way of doing things, as long as it's effective. And we have different groups of people in our country. We have people with different backgrounds, different cultures. And so how do we make that work? How do we make it an exchange where they'll learn from us, but we'll also learn from them? So I hope you understand that professional diversity really, really, really impacts what we do on a regular basis. And let's do what we can to promote that and bring more diverse people into our professions. Thanks very much.